Okay. All right. Look, good day, everyone. I thought today we'd talk about the management of the child in coma, and partly because it's a very common presentation. Children present in various stages of poor conscious state or in deep coma, and we need to be good at the differentiating the causes and the acute and ongoing management of such children. Now, many of the uh, talks we've had in these lecture series cover different aspects of the child in coma. And so if you haven't done so, I just refer you to, there's a lecture on acute head injury, there's one on status epilepticus. Some of the talks on care of the critically ill child also cover children in poor conscious state or in coma. There's a talk on the deteriorating patient, and that also covers children who are deteriorating from a point of view of their conscious level. There's a talk on meningitis and encephalitis, and one on fluid and electrolyte management. So they all have relevance to this particular topic. So I'm not going to cover all the same ground that I have talked about in these talks, but I'm going to cover some different aspects of care of the child in coma that I hope will be relevant to you. Some just make a few points about such children. It's always useful to start with a case, and I think, as I said, it's very typical that children present in with a poor conscious state, sometimes with seizures. Sometimes they have a febrile encephalopathy and a febrile cause preceding illness, and sometimes they are afebrile. So this was a 8-year-old girl, Asha, brought to hospital after 1 week of fever. She'd not been eating or drinking in the last 2 days, and on the day of referral, she could not be woken up and had a seizure. Again, a very common cause of presentation, and it's our challenge to manage all aspects of the care of such a child. And as you know, if you follow the stages of management of any sick child, this very much pertains to children with poor conscious state or in coma, then we need to take account of what to do at triage, what emergency treatment a child needs, how to take a pertinent, a relevant history and do a relevant examination to identify the severity of illness, and the underlying cause. Some laboratory investigations today, I'll talk a bit about neuroimaging because more and more CT scans are becoming available. I'll talk about some other tests that can be done that can reveal the causes of children with depressed conscious state or coma, and then come up with a differential diagnosis, often a main diagnosis or other differential diagnosis or comorbidities the child might have, and then give treatment and then supportive care, which is crucial for children who have impaired conscious state or in coma. Supportive care really is life-saving, and monitoring, again, crucial, and then discharge planning and follow-up, which we won't talk too much about today, but I'm really going to talk about the acute assessment and management of a child in coma or with very depressed conscious state. And the first thing I want to say, we often look at the Glasgow Coma Score, and we try to do that. It's perhaps not as relevant to infants and toddlers as what it is for adults. And the second thing you need to know about the Glasgow Coma Score or the Glasgow Coma Scale is that it's really designed for traumatic coma, traumatic causes of poor conscious state. It has some relevance to other causes of poor conscious state, but not quite as much as certainly not as much as it does to trauma. So I think the best at triage, then the best way to quickly assess a child's conscious state is the AVPU score. You know all about that. We've talked about that before. And as well as that, describe the motor component of the Glasgow Coma Score. The eye-opening and the verbal response isn't quite as useful, but the AVPU plus the motor component of the Glasgow Coma Score gives you a very good indication of the depth of the child's um, uh, poor conscious state. And so when you're describing the AVPU score, make sure you describe, well, is the child alert? Or if not, does the child respond to verbal commands and how do they respond? If not, does the child respond to painful stimuli? And you can do a noxious or a painful stimuli by a couple of ways. The general teaching is pressure on the supraorbital nerve, just underneath the eyebrow, or in a peripheral digit. I usually actually stimulate a peripheral digit, but you should record the motor response as either that which is purposeful. In an adult, it's purposeful. They'll reach up and grab your hand and push you away, or that's normal flexion. That is, they're moving towards the stimuli, but a normal flexion, a rapid arm flexion with usually with shoulder abduction, moving their shoulder out of the way, or abnormal flexion, and that's often slow arm flexion with shoulder adduction. The shoulder is not abducted but adducted, or extensor, abnormal extensor, or no response at all. And they're the levels of the Glasgow motor score. As I said, in the acute triage of a patient, you don't necessarily need to go through the eye opening and the verbal response, but if you do the AVPU score plus describe what the Glasgow motor response is, you also should, or if the child doesn't respond to any painful stimuli, then is the child unresponsive to both verbal commands and painful stimuli. It's important to describe actually what the child does, not just the level, not just the A or the V or the P, but what they actually do. And then you should record the pupil size, whether they're dilated or equal, and they react or are fixed to light. It's very important whether they're equal, whether they are dilated, whether they're reactive or fixed to light. So at the level of a triage assessment, that's what you need to do. We'll just go through that again. The Glasgow Motor Score is a bit more relevant to young children and infants, and young children. There's a very much similarity between the types of responses you get. For an adult, if they obey, they get 6, or an older child, if they obey, they get 6. If they move spontaneously, then an infant moves spontaneously, they also get 6. Localizes or withdraws to touch, that gets 5. Withdraws from pain gets 4. A flexion response to pain gets 3. Extension is often called decerebrate, so flexion, abnormal flexion with the shoulder adducted, and a slow abnormal flexion of the elbow with the shoulder adducted. That's often called a decorticate response, and extension is often called a decerebrate response. It's really just the as you get less of a score on the Glasgow motor score, that suggests an increasing depth of coma or an increasing risk of intracranial hypertension and increasing risk of um, uh, coning or herniation of the base of the brain. And then if the child has no response, then they get 1. So know the Glasgow motor score well, and in older children, of course, the verbal response or the eye opening is important too. But at triage, I think it's just good enough to do that. Now, this child had a temperature of 39.5, so already, from the history and from the assessment at triage, this falls into the category of a febrile encephalopathy, a febrile cause of coma. And it's important the first thing when you're trying to differentiate the different diagnoses that cause coma. Is it a febrile encephalopathy? Is it an afebrile? Is it acute or is it chronic? These basic things are very important in putting different diagnostic groups into categories. This child, of course, at triage, you measure the weight, so you know what doses of medications to use. This child had noisy breathing with a tracheal tug and a snore, and a respiratory rate of 44 with a saturation of 92. So none of those things are good. The airway is somewhat at risk. Noisy breathing with tracheal tug and snoring or grunting respiration, and fast breathing for a child of 8, and desaturation. The C for circulation was okay. The pulse was 146. It's a bit fast, but not slow. The capillary refill was 2 seconds. The pulses were strong and the hands are warm. So you can make an assessment that this child has an airway and a breathing problem. Circulation's okay. And then she was unresponsive to voice. she withdrew her limbs to pain and you heard that she had a seizure, and she was intermittently shaking her right arm and leg. So very quickly, within the space of a minute or two, you can make such an assessment at triage, and then you can start to, in your own mind, think what could be the differential diagnosis of this child's coma. Remember, you try every in many of these situations, you've got a golden hour to try to make a diagnosis, give emergency treatment, give all the comprehensive treatment that a child would need. This is not ongoing treatment, but the comprehensive sort of emergency treatment a child would need. If the first thing you would do for this child is put her in a position, in the recovery position, where she was able to protect her airway. If a child like this is lying flat on their back, they're one, likely to aspirate; two, their tongue is likely to fall back on their throat, and it's likely to cause airway obstruction. So anything that draws their jaw forward, such as being in the recovery position, where you often, when you put a child in the recovery position, you still need to manipulate their jaw and just bring it forward. And sometimes it's even important to sort of hold it there or apply a Goodell airway or something like that to maintain the opening of their jaw. But in a very short space of time, literally in the 5 or 10 minutes after you have done the assessment at triage, then the child should be on oxygen in a recovery position. They should have their airway should be supported in some way, whether it's um, by jaw thrust, by positioning, by passage of a nasogastric tube. If the child's vomiting, they should have their blood sugar tested. If they're seizing, an anticonvulsant, and then think about the diagnosis and give antibiotics. So those things are really all that's required in the golden hour of a patient in coma. There are indications at this point for intubation, and any child who's got a significant airway compromise, or they've got hypercarbia, that hypercarbia with a high carbon dioxide level, or hypoxemia if they're got oxygen desaturation, or if they've got severe signs of raised intracranial pressure, which I'll talk about shortly, or to facilitate scanning. If a child's going to have a CT scan and they're in a precarious position, then they need to be intubated for that. Or if they have intractable seizures that either compromise their airway or their breathing or their circulation, or if they need anticonvulsants that's going to compromise their breathing especially, or their airway. Children that need more repeated doses of diazepam or midazolam or phenobarbital or paraldehyde is likely to hypoventilate and have airway obstruction. And the safe thing to do would be to intubate those patients for the acute phase and get a scan as soon as possible. I wanted to get back on to some anatomy and physiology to start with. And first of all, the definition of coma. We all know what it is. We can recognize it, but what is it? Well, it's a profound state of unconsciousness from which the patient can't be roused. We know that. And broadly speaking, there are two sorts of lesions that can lead to coma. And one is a focal lesion in the reticular activating center, and that's in the brain stem. It's the reticular activating center is a little hard to find, but it's probably in the posterior aspect of the brain stem between the medulla and the pons, and it really is responsible for wakefulness. It connects up with the thalamus and it connects up with the spinal cord by what's called C fibers, and C fibers are usually nociceptive fibers or pain fibers. And that means that's why a painful stimuli will usually stimulate a patient to wakefulness or an adequate consciousness. And so a patient can have a normal cerebral cortex, they can have a normal cerebellum, their deep white matter structures can be normal, but if they've got a lesion in the reticular activating center, and that could be either a tumor or an area of stroke in that part of the brainstem, then they can have profound unconsciousness. Certainly in some situations, in some forms of encephalitis, that can particularly affect the reticular activating center, and children can be drowsy or sleepy for a very long period of time, for weeks or months. That's a previously well described situation. So it can either be a focal lesion of the reticular activating center or a child, more commonly, a child who's got a global cerebral injury that's affecting oftentimes both cerebral hemispheres and different parts of their brain stem. So we probably see the second type of coma more commonly, but we also see children that have got just a very, it can be a relatively small focal lesion that leads to unconsciousness. When you're assessing a child with coma, I've talked about you assess the airway, the breathing, the circulation, you assess the AVPU score and the motor score, and then assess for asymmetry or focality, like differentiating a patient as having a febrile encephalopathy or an afebrile encephalopathy or having an acute or chronic encephalopathy. Assessing for symmetry or asymmetry can be very helpful in identifying what type of coma the child has. Then you assess for because focality suggests a contralateral lesion in the cerebral cortex. And then you assess for signs of raised intracranial pressure, which we'll talk about, and then assess for the signs of the cause of brain injury. And that can be based on history or examination. We'll talk a bit more about that. And then I've spoken about this before, but our job in looking after such patients is to try to prevent secondary brain injury. There's often not a lot you can do about the primary brain injury, whether it's a head trauma or whether even if it's meningitis, you can get them onto the right treatment. But we have to identify the risks of secondary brain injury and prevent those. And secondary brain injury occurs from hypotension or hypoxia or hypoglycemia or ongoing seizures or cerebral edema or hyponatremia, major electrolyte imbalance. And so our job in a way is not only to treat the underlying cause, but to prevent secondary brain injury. That's the job of people providing supportive care to look after such patients, as well as trying to identify the diagnosis and provide curative care for the underlying cause. As I said, focality or asymmetry um, requires the assessment of the motor response on both sides. So usually I squeeze a digit, the distal digit on both sides and see if there's a asymmetry to the motor response. That's not so helpful if a child's lying on their side because they often move the freer arm more than they move the one that's lower, and so therefore put a patient in a position where they can respond symmetrically and equally on both sides and just check their motor response. As I said, significant asymmetry helps you in your diagnosis. It suggests a cortical or a hemispheric injury or some sort of condition on the contralateral side, on the other side of the brain. It doesn't tell you always where, at what level it is, because you can have a contralateral lesion of the cerebral cortex, you can have one of the basal ganglia or the thalamus, or but it tells you that there's a contralateral lesion usually. There's many signs of raised intracranial pressure, and I think we need to get good, especially when there's a lack of imaging, acute imaging in a timely fashion. We need to get good at assessment for signs of raised intracranial pressure. And I've just written all of those signs or most of the signs of raised intracranial pressure here. And some of them are signs of quite advanced raised intracranial pressure. And obviously we need to try to identify raised intracranial pressure in patients with impaired conscious state before they become very advanced. But you just need to have a knowledge of all of these signs and identify when they're present in your patient. Now, sometimes the sign will be present and it won't necessarily reflect raised intracranial pressure. The child with hypertension might just be in pain, or there might be some other cause of hypertension. But think about it in the child who's got impaired conscious state and hypertension, especially if they've got bradycardia as well. So coma, hypertension, and bradycardia should always suggest raised intracranial pressure. If they've got a sixth nerve palsy, that is a Duson's palsy, then that's a sign of raised intracranial pressure. In infants, we see sunsetting eyes a bit more commonly, and in infants a bulging fontanelle. But I think quite commonly what you see earlier on are um, abnormalities of breathing and behavior that can indicate raised intracranial pressure. Extreme irritability, a high-pitched cry, irregular breathing, groaning in pain, often teeth grinding. We often don't recognize this as being potential signs of it raised intracranial pressure. Now, of course, they can be due to other things, but we always should think to ourselves, well, could this child have raised intracranial pressure? Could it be a cerebral lesion that I'm missing? And certainly an abnormal flexion, the flexion I spoke about, where there's a slow flexion of the elbow with the shoulder adducted, not the shoulder abducted, is an indication of a cerebral lesion and potentially raised intracranial pressure. And extension, which is often an internal rotation of the limbs with extension of the arms. And sometimes, if you remember, in small children, you'll see that sort of fisting of the limbs, of the hands, fisting with the thumb underneath the fingers. You'll see that in some children, not always as a sign of raised intracranial pressure, but as a sign of cortical injury. Then there's signs we often imagine we'll look for, which is doing fundoscopy to look for papilledema. And papilledema can, the absence of papilledema doesn't mean a child doesn't have raised intracranial pressure, because papilledema typically, not always, but typically takes many hours or days to develop. And so the absence of papilledema doesn't mean the child doesn't have raised intracranial pressure, but the presence of papilledema usually means the child's got raised intracranial pressure. They can also have a focal lesion of the eye that can lead to edema of the disc, but usually in a poorly conscious child or a child who's got seizures, papilledema means they've got raised intracranial pressure. I'll show you some papilledema shortly. A skull X-ray we often do, or sometimes do, and that can show a child's got raised intracranial pressure by the appearance of copper beating, but that takes many weeks or months, and sometimes even years. So it's not a good indication of acutely raised intracranial pressure. A normal skull X-ray is often seen in children who have acutely raised intracranial pressure that's been there for hours, days, or weeks. And then there are signs on a CT scan, and a child can have raised intracranial pressure in a relatively normal CT scan, or they can have these signs, which I'll show you shortly. So edema, and edema, remember, edema is water, and water is hypodense, or of low density, so darker on a CT scan. A loss of a sulcal pattern means that the brain is more swollen, and you'll see some features of that, and then a sort of crowding of the posterior fossa. If the structures in the posterior fossa, especially on the lateral film, the lateral images, are very crowded, then that does suggest raised intracranial pressure. There's some other things that can cause it, but our assessment of raised intracranial pressure should be clinical and supplemented by such imaging. This is a normal fundoscopy of a child, and I just want you to see what the disc looks like. And so it's very clearly marked. The margins are very clear. The blood vessels you can see all the way to the center of the disc, or just off center. The fovea looks normal. These are two normal fundoscopic looks at the retina. Now, in children who've got impaired conscious state, if we ask an ophthalmologist to see the child, they'll often want to dilate up the pupils. It's very important that you make a decision as to whether or not it's safe to dilate the pupils, because if you're monitoring the pupils to see whether a child's got dilated pupils, then you need to be sure you're not using a long-acting mydriatic agent, a long-acting eye drops that will dilate the pupils for atropine eye drops dilate the pupils for many days and even weeks, and it can be a really a big problem if you're looking after a child who's got coma. So use no more than very short acting mydriatic drops, and even in some children, it's not safe to dilate the pupils up, and you'll either have to have a look through the pupils as they currently exist, or not be able to see the fundus at all. So be careful about the type of drops you use for dilating pupils in children who've got impaired conscious state. Tropicamide is relatively short acting. It lasts for about 4 to 8 hours, but even that can be too long in some situations. This is papilledema in a child, and you can see that the disc margin is not at all clear. That it's sort of white and fluffy. There's not a cleared, crisp disc margin, and you can see that the vessels look more dilated than what they did in the other image, which I put up here. So you can see the vessels very clearly, a single line, but in papilledema, the vessels look engorged. They look widely dilated, a little bit uh, uh, double vessel, and you can see the disc margin is not at all clear. This is another appearance of papilledema. It is a little bit less severe, but you can see a couple of other things in this. This is the normal disc with the crisp, clear disc margin, and this is the fuzzy outline of a disc margin where there's papilledema, again in a child. Um, and lastly, there's also in this fundoscopy, there is some increased pigmentation of the retina that you can sometimes see if there's hemosiderin deposition, but it's not the same as retinal hemorrhages, which I wanted to show you in this picture. This is a fundoscopy of a child who has cerebral malaria, and what you can see is there's some particular characteristics of cerebral malaria. This type of fundoscopic appearance occurs in more than half of all children who have true cerebral malaria, not children who have malaria and a febrile convulsion, but if they've got true cerebral malaria, because you get malarial parasites in the microvasculature of the brain that can sometimes cause um, uh, uh, stroke-like lesions or hemorrhage, then this is retinal. You can see the whiteness of the macula, even though there's here the optic disc looks fairly clear. So it's not papilledema, but the macula looks white, and there's evidence of cerebral hemorrhages. Often in malaria, often with white centers, you can see that each of the hemorrhages have white centers, and that's characteristic of cerebral malaria. Um, there is a differential diagnosis of retinal hemorrhages, and that includes trauma. You can have traumatic retinal hemorrhage, especially, unfortunately, non-accidental injury where a child is shaken and they get shearing forces on the retinal vessels and they can have retinal hemorrhages. Or if you've got a child with coagulopathy, that retinal hemorrhages can occur, or in children who have leukemia, they can develop retinal hemorrhages. So this image is of a child who's got cerebral malaria, but when you see retinal hemorrhages, think of the other causes which can cause a depressed conscious state or coma. As I said, the copper beating that you see on X-rays really doesn't tell you about raised intracranial pressure in a child with an acute coma. It's a manifestation of months of impaired, not always impaired conscious state, but raised intracranial pressure, and so if you see it, it's because the child's had intracranial hypertension for many months, usually, to get that level of remodeling of the bones of the skull. I want to talk about the role of lumbar puncture. And the first thing I want to say is that there's no such thing as an urgent lumbar puncture, no such thing. And um, there are some good indications for a lumbar puncture, but no such thing as an urgent lumbar puncture, because usually you can get as much diagnostic information from delaying a lumbar puncture until a child is very stable and until it's very safe to do so. It doesn't mean you shouldn't do a lumbar puncture in a child who has febrile encephalopathy, who doesn't have contraindications. You should, but it doesn't necessarily mean it's urgent until. So you have to satisfy yourself that the child doesn't have raised intracranial pressure, and before you do that. But the indications for a lumbar puncture are if you cannot confidently exclude a diagnosis of malaria based on clinical features of alone. And then you get a lot of information. If based on your assessment of the child, you can't be sure they don't have malaria, then meningitis, then it's a good idea to do a lumbar puncture. As long as they don't have, I'm just going to um, mute this person. Yeah, that's okay. Um, as long as they don't have a contraindication, and you just need to know the contraindications, and they are having a motor response that's worse than withdrawal. So if the patient is doing worse than withdrawal, like an abnormal flexion response or an abnormal extension response, that they could be signs of raised intracranial pressure, and you shouldn't do a lumbar puncture. If the child's got a coagulopathy, if they've got a local skin infection around on the back, or if they've got severe respiratory distress, and I think in some ways that's the most common contraindication where I've seen lumbar punctures go badly, and that is a child who's got significant respiratory distress or airway compromise, and they're curled up into a ball and held tightly while someone does a lumbar puncture, and then they can sometimes have apnea or have airway obstruction during it. So don't do a lumbar puncture in those settings, but in any other child who has impaired conscious state or febrile seizures, and you can't confidently say that they don't have meningitis on clinical features alone, then it's worthwhile doing a lumbar puncture. That's the role of lumbar puncture. I wanted to say something about the role of CT scans because, as I said, they're increasingly becoming available, and there's a number of things to take into account. The first one is um, whether whether you have contrast available or not. And there's certain information that you can get from a non-contrast CT scan. If you've got a traumatic form of coma, then a non-contrast CT scan is all you need, because what you'll be seeing on a non-contrast CT scan is the question is there blood or not? And if there's blood, where is it? Is it outside the brain? Is it inside the brain? Or if you've got a child who's got a sudden onset of severe headache, and you might want to know whether they've got an intracranial bleed, then a non-contrast CT scan is usually very informative. It'll exclude acute hemorrhage, but um, and a non-contrast CT scan will also show some other things. And if you've got a stroke, if a child's had a stroke, for example, that is more than 12 or 24 hours old, then you'll see this level of this hypodensity. Remember, I said hypodensity means that there's more water in the brain tissue, and therefore it's darker. And hypodensity like this suggests a stroke. Remember that the CSF is dark because it's water, and anywhere in the brain, if you see increased water, it's because of increased water within the brain substance, and that could be cerebral edema, or it could be a stroke where there's an influx of water into the cells. So you can see hypodensity on a non-contrast CT scan. But if you're looking to exclude an abscess, a cerebral abscess, or a tuberculoma or a tumor, they all require contrast. You'll often miss an abscess or a tuberculoma if you don't give contrast, because you don't see the contrast enhancing part of it. And sometimes a cerebral abscess, for example, can be a similar density to the rest of the brain tissue. So you won't always pick it up if it's an isodense or it's a similar density to the rest of the brain tissue, but you will do if you give contrast. The same with tumors. They can look rather similar to the brain substance in terms of the color or the grayness of their the density of the lesion. But if you give contrast, then your contrast shows up the blood vessels, and if there's a capsule around it, or if it's a highly vascular tumor, you'll be able to see it. Contrast also may enable you to see meningeal enhancement, which means the meninges enhanced with contrast. That's a little harder to see. But the main thing is to know why you'd use contrast and why and in what situations a non-contrast CT scan would be acceptable. Okay, we'll just go through a few images now. And remember I said that if you're looking for um, signs of raised intracranial pressure, one of the things you look for is whether or not the normal sulcal pattern, the dark spaces in between the cerebral gyri are present or not. And in this CT scan, there's almost a loss of the sulcal pattern, and there's a loss of the what we call the grey-white differentiation, where you have the cortex and the subcortical region is very different in terms of grayness. It all looks rather the same. This is diffuse cerebral edema occurring in a child who had pneumococcal meningitis. And so you can see several things from this. One is that there's diffuse cerebral edema, there's loss of grey-white differentiation, there's increased brain water because it looks darker than what you'd normally expect. And the differential diagnosis of this is broad. It happened to be in a child with meningitis due to pneumococcus, streptococcus pneumonia, but it could be from cerebral edema from any other cause, such as an asphyxial event or hypoxic encephalopathy or cerebral malaria can give you a picture that's rather similar to this if it's advanced or as I said, meningitis. TB cerebritis can produce a lot of different sorts of pictures, and this is cerebritis from tuberculosis, or TB meningitis, TB cerebritis in a child, and a contrast enhanced CT scan. And you can see the contrast enhancement where there's asymmetry of the left parietal lobe, and there's a lesion here that's, it turns out this was due to tuberculosis. It could be some other things. You can get contrast enhancement around an abscess or contrast enhancement around a focal area of meningeal enhancement, but this was tuberculous cerebritis. Remember I said a non-contrast CT scan will be able to identify blood, and the question you have is whether the blood is inside the brain or outside the brain, and outside the brain can be subdural hematomas or extradural hematomas. And this is an example of a subdural hematoma. And then you need to ask yourself whether it's acute or chronic. And if it's acute, it'll be quite white, hyperdense. If it's older than a few days, if it's coming towards a week, then it'll often be a similar density to the brain substance. And if it's even older, it may be a similar density to CSF because water accumulates and the hemorrhage liquefies over time. And so in this setting, you would say that there's an acute hemorrhage in the subdural space, but you notice that the subdural spaces are rather large, and this is acute on chronic subdural hematomas. So the child has had chronic some subdural hematomas that occurred some time ago, but they've also had a more acute bleed into the subdural space. So you can see quite a lot from CT scans in that regard. This is an extradural hematoma. Remember, it's a concave appearance of the brain, and you can see that there's mass effect. The other thing you can see from either contrast or this is a non-contrast CT scan where you're looking for blood and you're looking for mass effect. That is asymmetry or edema adjacent to the area of bleeding, and mass effect, which what you're looking for is to whether there's midline shift and whether the ventricle is compressed, which you can see on the right side, the ventricle is quite compressed relative to the left side. And it does look like there's a lot of edema here. So this is an acute extradural hematoma, usually from direct trauma. This is a bit different, and I want you to focus a little bit on, when you're looking at a CT scan, focusing a bit on the relative density of different sides. And I think you can probably see quite starkly here, there's a hypodense lesion in the deep white matter here, not the cortex, but in the deeper white matter. It's hypodense, right? It's darker there's more water relative to the other side. And there's also it's also a bit more swollen. The brain is more swollen, so the sulcal pattern on the left side is more evident, and on the right side you can't see the sulcal pattern as much. And this is a stroke that's occurred in the basal ganglia and the caudate nucleus. This is a stroke that's led to edema, and edema means that the CT scan is blacker. This was a CT scan done a little bit earlier where you can see even now it was thought to be normal at the time, but actually you can see a hypodense area in the same space in the where the basal ganglia should be. And so this is a stroke of the basal ganglia, and it progressed in terms of edema, you can see. So I want you to be able to look at the density between hemispheres and then be alert to whether or not there's more swelling on one side than the other, whether the sulcal pattern is normal or not. In the earlier scan, the sulcal pattern was reasonably normal. You could almost see it being normal and symmetrical on both sides, but there was a hypodensity in the basal ganglia, and you can see that the ventricle on the right side is more compressed. This is I showed you a TB cerebritis before, but this is another example of TB cerebritis where you've got a hypodensity, more edema or hypodensity in the posterior fossa. This is a cerebellum in the posterior fossa, and what you can see is an area of I just outlined the area of hypodensity here, and this is what we sometimes call a tuberculoma, but it's really an area of stroke or hypodensity or caseating inflammation in the posterior fossa. So again, this could be due to a tumor. It could be due to a posterior fossa stroke or TB cerebritis. So I'll just briefly talk about the care of the child who's in coma. Well, I've spoken already about the airway, the breathing, the circulation. Always, always, this is so important. You should try to nurse patients 30 degrees head up. The recovery position is fine, but you can also get patients 30 degrees head up in the recovery position, or you can have them in the recovery position where the airway is protected if it's not a threat. 30 degrees head up will reduce their intracranial pressure. Make sure you pay attention to their glucose, anticonvulsants. If there's some antidote to a toxin or drugs that the child might have ingested, there's not too many antidotes, but if a child happens to ingested opioids or benzodiazepines, then there are antidotes. Naloxone, flumazenil can be helpful in that regard. Or if you think there's a toxin or a drug ingestion, then consider whether or not some other treatment for that should be given. You should avoid fluid overload and only give isotonic fluid, Hartmann's solution or otherwise, and at 50% of maintenance. You need to make sure the sodium is not too low and it's in the normal range or even the high normal range, and check other electrolytes and their full blood count. You should try to protect them from aspiration with a nasogastric tube, and when the child's up to it, then nasogastric feeding can be useful. And then I'll talk a bit about blood pressure aims in children with coma. Obviously, in the early stages, you don't feed patients while a child's unstable, but you should have some aims about their blood pressure, and it's based on the notion of how you assess, in the absence of a monitor, how you assess their cerebral perfusion pressure. Usually in children with a coma, you can assume the intracranial pressure is around about 20 millimeters of mercury. Now, if you, the normal being about 5 to 10. So you can assume if they've had a stroke or if they've got meningitis, that their intracranial pressure is a little bit higher than normal. It may be much higher than normal, but 15 to 20 would be normal. We know that if a child has a brain injury, whether it's meningitis or a trauma or any cause, then they'll be better off if they have what's called a cerebral perfusion pressure of around about 50 millimeters of mercury. And that's the mean arterial pressure minus the intracranial pressure. So that means you need to aim for a blood pressure that's a little bit higher than normal, not in the upper limit of the normal range. And so if you've got a child who's got an intracranial pressure of, assuming it's 20, then you should be aiming for a mean arterial pressure 50 above that, which is about 60 or 70. That'll give you an adequate cerebral perfusion pressure. If you think about it, if the child's got a intracranial pressure of 20 and you're only aiming for a mean blood pressure of 40 or 45, then their cerebral perfusion pressure is quite low. It might only be 20 or 25, and that's often not enough for blood flow to get adequately to the brain. So you don't want them to be hypertensive. You don't want their blood pressure to be high, but on the other hand, you don't want them to have low blood pressure. If they're generating a high blood pressure on their own, then just as long as it's not too high, that's okay. Children with a brain injury will often generate, because of a physiological response, often generate a blood pressure that's a bit higher than their normal range. That's a normal physiological response, and you shouldn't necessarily try to bring it down unless it's at the level of malignant hypertension that's making their brain injury worse. So just have a concept of an assumption of intracranial pressure being 15 or 20 millimeters of mercury, and trying to achieve a cerebral perfusion pressure by looking at the mean blood pressure a child has. When you're trying to consider what treatment a child requires, we often just give antibiotics and antimalarials, but we should have a way of trying to identify the cause and give specific therapy. And so again, there's several key questions you should ask. One is it a febrile encephalopathy, or is it an afebrile cause of poor conscious state and coma? If it's a febrile encephalopathy, then they might have meningitis or TB or encephalitis or malaria. If it's an afebrile cause of coma, then it could be trauma or toxin ingestion or drug ingestion, or it could be hypertension. Hypertension can cause coma, or it could be a stroke. You need to think that's an important differentiating feature. Is it febrile or is it afebrile? Is it focal, remember I said, or is it symmetrical? So a focal cause of coma, often a stroke or a tumor or a bleed. Or is it symmetrical or some global brain injury, like you could see with encephalitis? Is the deterioration acute, or is it subacute, or is it chronic, right? So again, these questions, febrile, afebrile, focal or symmetrical, acute or subacute, they're really important questions for you to be able to describe about any child who's got depressed conscious state or coma. Is the raised intracranial pressure, and if you can, what does the scan show? That will give you a good clue. And then, of course, there's curative treatment for each of these different causes of impaired conscious state. I wanted to just lastly touch on one cause of encephalopathy that we often miss, and that's hypertensive encephalopathy. And it's not very common, but we see it quite a bit in children who've got a nephrotic syndrome or nephritic syndrome. They often have a severe hypertension, and they may have seizures, or they may be irritable, they might have depressed conscious state. And there's a type of impaired consciousness that occurs in hypertensive encephalopathy called PRESS. It's a bit more common in children, but does also occur in adults, and it's called posterior reversible encephalopathy syndrome. And I describe it because if you can identify a child who's got PRESS with malignant hypertension, and you can treat their hypertension, then the changes that you see on a CT scan, which I want you to look at this CT scan, especially the one on the left. I've just put some arrows there, but you can see the hypodense lesions this is in the cerebellum. Hypodense lesions in the cerebellum. It's a posterior and it's reversible. So if you can treat their hypertension, usually that goes away and they come back to a normal level of consciousness and their seizures stop. And as I said, we see it more commonly in children with nephrotic syndrome or nephritic syndrome, but any cause of malignant hypertension, especially acute renal failure, can give you a hypertensive encephalopathy. And there's a variety of different drugs. We'll talk more about hypertension in another lecture, but there's a variety of different drugs that you can use to treat severe hypertension. And often it's not just one drug that works, especially if a child's got severe hypertension. But using starting with one drug, and if that doesn't work, optimize the dose of that drug, and then use another medication that has a different mechanism of action. And so our options are calcium channel blockers like nifedipine or amlodipine, or a beta blocker like atenolol or propranolol, or an ACE inhibitor like captopril or enalapril. And then there's some intravenous options like hydralazine, or a continuous infusion of sodium nitroprusside. Now, some of those drugs won't always be available, but you need to know what types of antihypertensive medications are available, what their mechanism of action is, and you need to know in what circumstances wouldn't you use such drugs. So, for example, in a child who's got renal impairment, you wouldn't use captopril or enalapril. You wouldn't use an ACE inhibitor. In a child who you're worried might have raised intracranial pressure, you might not use a beta blocker because it might slow their heart rate and make their assessment of their level of consciousness confounded. On the other hand, you might use it because you need to control their blood pressure, and you just have to take that into account. There's certain circumstances under which you'd ideally use certain drugs, but usually we start with a calcium channel blocker and then elevate the the treatments if that's not working. But it's a very important diagnosis to make because it's reversible, and it's reversible with just controlling the blood pressure. So if you next see a child who's got nephrotic syndrome or glomerulonephritis with a hypertensive encephalopathy, then this is what their CT scan will often look like, and if you treat their hypertension, it'll often get better. Um, that's all I was going to say today. I'm going to stop sharing, and if you've got any questions, I'm happy to answer anything you might ask. Thanks.